Welcome to the University of Toronto Joint Center for Bioethics Seminar Series. I'm Angel Petropanagos, and I'll be the moderator for today's session. Our speakers are Bryn MacArthur, Alexandra Campbell, and Andrea Bianchi, and their seminar is entitled Licit Substance Use in Physical Rehabilitation Settings. Before I introduce today's speakers, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Center for Bioethics website. The format for our seminar is a presentation followed by our speakers, followed by a facilitated discussion period. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Now, it is my pleasure to introduce today's speakers. Bryn MacArthur is a student occupational therapist at McMaster University who has an interest in rehabilitation ethics. She completed her Bachelor's of Science at the University of Waterloo in 2020 and subsequently worked with persons with disabilities in community settings. Alexandra Campbell is a fellow in clinical, organizational, and research ethics with the Center for Clinical Ethics at Unity Health. She's currently on a placement with the University Health Network. Before entering the field of bioethics, Alexandra worked for several years as a lawyer. And Andrea Bianchi is a bioethicist and a clinician scientist at the University Health Network, an affiliate scientist at Kite Research Institute with Toronto Rehab, and an assistant professor at the Dalla Lana School of Public Health, University of Toronto. Andrea's clinical ethics work primarily focuses on issues in rehabilitation ethics and cognitive impairment. So my pleasure, Bryn, Alexandra, and Andrea, over to you.
Amazing. Thank you so much, Angel. And I'll just attempt to share my screen. Hopefully this still works. Okay. And if you don't mind just verifying that you're able to see everything in full screen.
Looks good.
Beautiful. Okay, so thanks so much for the introduction, Angel, and thanks everyone who's attending this presentation. We're very excited to speak about this topic with you and to hear your thoughts, questions, comments as we move along, and hopefully there will be ample time for questions and comments afterwards. So the goal of today is to make it through the following 4 points. So we will start off today's discussion by introducing a case that we'll be reflecting upon throughout the presentation. We'll then talk about physical rehab, what it is, and we'll talk about person-centeredness. We'll spend a little bit of time speaking about substance use and healthcare, and then we'll talk about what it may look like to implement a harm reduction approach when it comes to illicit substance use in rehab. Okay, just in terms of disclosure, so Alex and I are employees of publicly funded healthcare organizations, so just disclosing this for everyone's knowledge. We do have views on matters of ethical interest, and those views are not necessarily those of our employers. Okay, so as mentioned, so we're going to jump into a case to set the stage, and we will be coming back to this case throughout the presentation. So I would encourage you to keep it in mind and reflect upon it as we move forward. So the case, so we're going to speak about a person that we'll refer to as Courtney, and Courtney is a 36-year-old female who was recently in a motor vehicle accident, which resulted in spinal and upper extremity fractures. After the accident, Courtney was immediately admitted to an acute care setting, and then she proceeded to be admitted to an inpatient rehabilitation unit. The rehab team working with her recommended that she participate in a number of therapies. Courtney consented to all recommendations and expresses a sincere motivation to get better, to be discharged to the community. Courtney has a good support network of friends, and these friends visit her frequently, and they frequently take her outside for fresh air. And we can imagine that this case occurred prior to COVID, where there were restrictions in terms of the number of people coming, in terms of exiting, entering the building, that this was under normal circumstances where this was entirely permitted. On one occasion, a clinician who's working with Courtney sees Courtney outside with this group of friends. The group appears to be drinking alcohol and smoking cannabis. Although both of these substances, namely alcohol and cannabis, are legal, the rehab center does not permit patients to use these substances during their inpatient journey, irrespective of whether they are legal substances or whether they're consumed off property. So this is something that is entirely prohibited for this center for inpatients. So again, would just encourage you to keep this in mind. And I would actually encourage you just right now to reflect upon your initial reactions in relation to this case. When thinking about Courtney, when thinking about the fact that this center doesn't permit patients to use these substances, thinking about the circumstance that Courtney finds herself in, just reflect upon your immediate reactions. And then we're going to be coming back to this case as well. So we'll spend a little bit of time talking about physical rehab. And so what it is, so physical rehabilitation, and some of you who are attending today may be familiar with this concept, and so I'll go through this relatively quickly, but it does provide therapeutic techniques that aim to improve an individual's functioning and to reduce disability for people with various physical and cognitive impairments, both those that are congenital and also acquired. It may be important just to remember and to note that people of any age may require rehab at any time and for a variety of reasons, such as when people are recovering from surgery, from illness, motor vehicle accidents. So there's a variety of reasons that as to why people may end up receiving physical rehabilitation. The primary goal of rehab is to reduce disability and improve and or regain functioning through methods that promote independence and autonomy. And as a person who primarily focuses her ethics work in a rehabilitation context, these words, independence, autonomy, trying to regain functioning, these are really the key goals that people try to work on when they are working in a rehab context. I should also note that a physical rehabilitation context, while it's similar to acute care in terms of the types of professionals helping individuals, it is very much allied health professional driven. So there are a lot of, so of course, every patient who's admitted to an inpatient rehab unit will have a most responsible physician. However, their therapy is primarily guided by, and their goals are primarily focused upon by occupational therapists, physiotherapists, recreation therapists, spiritual care, there's kinesiologists. So it really is an allied health professional kind of driven environment to a large extent. Additionally, it's important to note that rehab improves patient outcomes, it shortens hospital stays in terms of acute care hospital stays, and it helps patients flow through the system, and it also reduces costs in terms of preventing individuals from needing to be immediately admitted back into an acute care setting. And the GTA Rehab Network, which is where this information is coming from, does certainly do research on this and has a lot of great work and information to provide. So rehab can occur in various places. Acute care hospitals is where a rehab journey will oftentimes commence. There are inpatient rehabilitation hospitals. People may receive rehab on an outpatient basis, in addition to receiving rehab in the home or in a community setting. And so the primary focus of our presentation today is really on inpatient rehab hospitals, but many of the perspectives that we're going to be speaking about may translate to other contexts as well. We're really focusing in on inpatient rehabilitation hospitals because that's the primary environment that we are contributing to and reflecting upon this work. Okay, so when we're thinking about person-centeredness, so a person-centered philosophy of care is really at the core of rehab. And in thinking about person-centeredness, it's sometimes helpful just to differentiate and think about how person-centeredness differs from patient-centeredness or patient-centered care, both of which are kind of buzzwords or key concepts that we hear thrown around in the healthcare world quite frequently. And so person-centered care, which is really the focus of our presentation and what we are kind of hanging on to throughout this, it recognizes that every patient is a person who has an identity, has goals, has values, beliefs that extend beyond hospital walls. So it does really try to encourage a holistic approach to patient care. And so person-centered care, we recognize that it is presumably, I would say actually very important for all health organizations and types of healthcare settings, and maybe particularly important for rehab to really have this as a primary or driving factor, because the primary goal is increasing independence, improving functioning, quality of life prior to discharging most commonly to the community, whereas from acute care, people will sometimes be discharged to rehab. So it is oftentimes seen as kind of the last stop prior to discharging to the community, which is why it is of the utmost importance. So when we think about what person-centeredness may look like or should look like in a rehab context, so we know that a patient's rehab journey and their care provision will likely depend on individual values, beliefs, goals, and post-discharge preferences. So when we think about person-centeredness and discharge preferences in particular, we can think about the following kind of scenario. We can imagine that a person with a new physical disability expresses wanting to be discharged back to the community, to their old 2-story home that has stairs and has no main level washroom. We can further imagine that this individual is unable to ambulate at the moment by themselves. They are walker dependent. They are unable to climb stairs at the moment, but this is really where they want to be discharged to, namely an environment that has stairs and no main level washroom. We can imagine that the reason as to why they want to be discharged to this particular location, though it is not recommended by the care team, it's because their partner recently died in that home, that they want to go home and that they want to live the rest of their life in this particular physical space, that they don't have the finances to renovate their home. And so ultimately they're willing to go to this place. They're willing to take some risks and willing to try to climb the stairs and to use the washroom that's available to them, even though there are risks involved in that given their current condition. So based on these goals, based on these values, based on the rationale, based on the options available, perhaps the rehab team will develop recommendations accordingly. So they may spend, for example, a substantial amount of time on stair climbing. They may allow this person to remain in hospital as an inpatient for a longer period of time in order to make sure that every at-home support is in place to mitigate falls. So this is just a simple example, I think, but an example that demonstrates person-centered care and that it does involve maintaining a holistic view of patients and really empowering patients to participate in decisions about care provision and discharge planning so that their goals can be realized. So with that, I'll pass it over to Alex, who can speak a little bit about substance use in healthcare.
Thank you so much, Andrea, for starting us off. And yes, I'm going to speak very briefly about substance use and healthcare very generally. So yeah, substance use in healthcare. It's probably no great surprise that the common practice in inpatient medical settings is to strongly discourage or in fact require that patients abstain from all substance use, regardless of whether the substance in question is legal or illegal. Substance use describes the use of drugs and alcohol, including cigarettes, illegal drugs, prescription drugs, inhalants, and solvents. And it should be noted that substance use is distinct from substance use disorder. Substance use is broader than substance use disorder, as is defined by the DSM-5. We should start by saying that it's very likely that there's good intention behind strongly discouraging or prohibiting substances when we're thinking about health consequences of substance use. We're all aware of the negative consequences to health, in particular, of substance use. Cigarettes, for example, are highly correlated with certain cancers, and about 80% of the deaths from COPD are related to cigarette use. Alcohol also carries known risks. Even cannabis, which is sometimes perceived as a more innocuous substance, is linked to short-term and long-term health risks. There's also the risk associated with perhaps substance use making a patient less enthusiastic or engaged in their rehab therapy if that substance use makes them more lethargic or apathetic. So given that strong discouragement or prohibition is the general practice, we should note that typically a patient is provided with some options by the clinical team in order to help them to abstain. And providing patients with options to manage their withdrawal symptoms or their cravings may be considered a way to promote patient involvement and autonomous decision-making in a way that aligns with person-centeredness. It does involve providing patients with options as to what kind of approach they might like, whether that be with nicotine replacement therapy or peer support or counseling or whatever it might be that would help them with their substance use. I think there might be another point. Oh, there we go. Thank you. Additionally, supporting abstinence might be said to align with principles of beneficence and non-maleficence, because encouraging abstinence means that the patient is not harming themselves through the use of substance, and that there is a benefit involved with staying substance free. But it should also be noted on the other side of things that while that there very well may be good intention behind abstinence-only policies, there are distinct potential harms that can be associated with such policies. So the substance use management, abstinence as substance use management can motivate patients to find alternative and potentially dangerous ways to use substances, or they may end up refusing to receive care if they feel that they are not a fit for the program because of their substance use. Also, there's the issue of early discharge, whether that is because the patient discharges themselves early against medical advice, or whether the patient is discharged by staff because they're not adhering to the policies relating to substances. There's, again, the risk of more dangerous substance use behavior because perhaps it's covert or possibly using substances off label, if you were. And then there's the issue of stigma on the part of staff toward those who use substances. So if another risk is if abstinence is required and a withdrawal plan is not effected appropriately, withdrawal symptoms can be very painful and distressing for everyone. And finally, requiring undesired abstinence can lead to challenging dynamics to exist between patients and staff. Staff find themselves in the awkward position of being the health champion of the patient, but then also having to police the patient's substance use behavior. Now, this slide, we're addressing the likelihood of post-discharge abstinence. And while it is likely a hope on the part of many that insisting on abstinence while a patient is an inpatient will extend to their life post-discharge, that is actually not borne out by the evidence. Short-term interventions for substance use, such as abstinence during a hospital admission, are known to be insufficient for generating long-term behavioral change, especially if that change wasn't desired by the patient themselves. So Andrea started us off with a hypothetical case, and I will just quickly take us back to that case because we're going to pick up and look at it again. Courtney, who we met earlier, is 36 years old. She was recently in an MVA, which resulted in spinal and upper extremity fractures. She was admitted first to acute care and then inpatient rehab. The rehab team recommended numerous therapies. She consented to all the recommendations. She wants to get better. She has a great friend network and they visit regularly and take her outside. She is very honest with her clinical team. She tells them that she intends to smoke cannabis off hospital property and when she gets home. And so she's somebody who's making an autonomous, well-informed decision, knowing the risks of cannabis, to continue to use this legal substance and not abstain in accordance with clinical recommendations. And as Andrea mentioned earlier, our work suggests that threatening discharge or failing to offer Courtney support would actually oppose what it means to provide person-centered care. So now I think I'm going to hand it off to Bryn.
Great, thank you, Alex. So with all of this information that we've gotten, we're going to look at what the rehab team should do in the case of Courtney. So person-centered perspective would presumably involve acknowledging Courtney's plan to smoke cannabis, both during and after her rehab admission, as well as working with Courtney to explore how cannabis may influence her rehab goals, and then establishing mutually agreed upon parameters about when she can use cannabis so that it's not interfering with rehab therapy itself. For example, only using cannabis after completing any of the strenuous activities in the therapy gym. Person-centered approach does come with taking certain risks and teaching new skills. So for instance, if Courtney's substance use puts her at a greater risk of falls, and this is a risk that Courtney is willing to take because she would like to engage in cannabis use, then the team may decide to teach her how to fall safely, how to get up, whether her home environment should be altered to reduce any possible harms, and so on. And if person-centered care is an ethical philosophy to prioritize in rehab, then working in accordance with Courtney's overall goals and values is extremely important. We also acknowledge the importance of a successful discharge. So if a person will presumably engage in legally permitted activities post-discharge, in the case of Courtney, substance use, then it may be worthwhile for clinical teams to consider what these activities look like in the community while the patient is still in rehab. So as described in Courtney's case, Courtney explicitly informed her care team that alcohol and cannabis are a regular part of her and her friends' lives, and that it's extremely unlikely that she will maintain abstinent post-discharge, irrespective of the rehab center's policy. So ultimately, substance use is going to alter thinking and behavior, and if Courtney receives rehab while sober, but then uses substances when discharged, then her ability to perform certain activities and the activity's level of risk may differ from what the clinical team witnessed in rehab inpatient care. And if a person commences new activities post-discharge, for example, substance use, they may encounter unanticipated challenges that interfere with their meaningful and successful transition home. Rehab is typically an in-between space from acute care to the community. And so therefore what happens in rehab should almost mimic what is happening in the community. And rehab is supposed to prepare people to live as independently as possible and to offer care that does align with individual goals, values, and preferences so that people can have that successful and meaningful transition back to the community. Now, looking at harm reduction and person-centeredness. So harm reduction is a philosophy of care that aims to reduce harms associated with a particular behavior. For the purpose of this, harm reduction is referring to mitigating any potential harms that come with continuing to use illicit substances during inpatient rehab treatment. Person-centeredness may sometimes align with harm reduction, depending on the person. But overall, if the goal of rehabilitation is to provide person-centered care to all who may benefit, then it seems as though a harm reduction approach may be a suitable alternative to an abstinence-only policy. Now, what would the harm reduction approach look like in rehab in terms of substance use? Well, we think that it would encourage patients to be transparent about illicit substance use, offering support about when and or how to use substances during rehab and post-discharge, as well as providing counseling for patients who want to abstain. Now, the goal of harm reduction approach is to minimize any harms in relation to substance use, while also enabling patients to gain the many benefits that come from rehabilitation. So patients can receive rehab in a way that aligns with goals and values, and it would empower the team and the patient to prepare for a successful and safe discharge. And back to Andrea.
Thanks so much, Bryn. Okay, so we know that what we are arguing, at least, is that illicit substance use, when we think about person-centeredness, and when we think about the possibility of harm reduction being very relevant to person-centeredness, we know that substance use, illicit substance use in rehab, and thinking about the philosophy of rehab, it seems like it may be an ethical route to go and to follow, as opposed to premature discharge, these conflicts with team members. But we also recognize that there are very likely a number of opposing arguments being put forward. One of the arguments that could be put forward is that patients who actually use substances will not benefit from rehabilitation. This is something that we've certainly heard, but in response to this, we would at least posit that this claim is unwarranted, as demonstrated by one spinal cord rehabilitation program's pilot program in British Columbia. And so I will certainly say that this is one pilot program that we are drawing from. The article is fantastic, and we can provide references to folks after the presentation if you're interested. But basically what this spinal cord program did is they implemented a harm reduction approach pilot program for patients who use both licit and illicit drugs and who have alcohol and drug dependencies who are either unable or unwilling to abstain from use. And I think that that second point, a person's unwillingness or a lack of desire to abstain when provided with that option, is what is specifically important to keep in mind, because it really highlights that some people do identify with and may want to continue using, recognizing the potential harms. And so what this program did as a pilot project is that they decided that if a patient wants to abstain from substance use, then they would offer withdrawal and abstinence support, because they did recognize abstinence as the ideal basis of health. And that's a quote. But the program responded to the fact that abstinence ultimately isn't a realistic option for many patients, and it's unlikely to follow through after discharge if it is required during an inpatient stay. And so what the program decided to do is to really focus on reducing conflict between patients and staff, which can stem from were stemming from differing responses related to substance use. They decided to focus on increasing the number of completed rehabilitation programs for people with substance dependencies, and to maintain a relationship with patients post-discharge, which is something that is incredibly important as patients continue their rehab journey into the community, but would unlikely occur if a relationship was ultimately destroyed or just, unfortunately encountered a number of obstacles because of substance use. And so what they found, and so there were a minimal number of patients who were enrolled in this pilot program, and this could be because of people's willingness or unwillingness to bring forward the fact and to admit to using substances that were licit and illicit. But the program did predict that patients in this program experience less harm. Staff ultimately did express having a better work environment, and they predicted that the healthcare system would incur fewer costs, but of course this would need to be determined over a longer period of time. And one of the other factors that I think, or one of the other things that I think is important to note that came out of this project, is that patients completed their rehabilitation program. They did receive support, and that a number of the patients actually looped back with the clinicians for follow-up. So they did maintain a relationship because of the minimal amount of conflicts or no conflicts that arose as a consequence of their substance use in and of itself. So it doesn't seem, just based on this one study alone, and we recognize that this is just one example, not a lot of work has been done about this specific type of program in a rehab context, but it seems as though patients who use substances can absolutely still benefit from rehab if given the opportunity to do so. I'll pass it over to Alex for the last few slides.
Thank you, Andrea. So another concern that many people might have is, what about staff safety? Is this going to be safe for staff? Do staff not have the right to work in an environment that is safe and secure and isn't, doesn't have patients who are perhaps behaving in unruly ways because of their substance use? And we would say yes, absolutely. Not only do staff have the right, should have a safe work environment, but other patients as well should also have a safe environment that doesn't involve patients being unruly and disruptive because of their substance use. But what we would say in response to this concern is that it's not necessarily the substance use that is the problem. It would be the behavior that could happen as a result of the substance use. And so we don't think it would be a proportionate response to say that there can be no substance use at all. What we would say is that there should be techniques and approaches to manage this and to reduce the possibility of unruly disruptive behavior that is associated with substance use. We would, So in Courtney's case, perhaps that would involve a conversation with her in advance and a discussion, negotiation about when she might want to use cannabis. Maybe that would be something that could be done in the evening, restricted to evening time, or with another patient. It might be appropriate to even have a managed administration of a substance in order to help ensure that behavior wouldn't become inappropriate as a result of substance use. But we think that it would not be proportionate to this concern to say that there can be no substance use because of a potential negative outcome that we believe can be managed and addressed and planned around. And so in conclusion, we'll leave you with just a very few takeaways, key takeaways. First, person-centeredness is an important part of providing ethical care, perhaps especially important in the context of rehab, where enabling independence and autonomy are so central. In order to ensure all patients can benefit from rehab, it's important to provide patients with a treatment plan that considers their post-discharge lifestyle and values, and that may include their illicit substance use. And finally, it may be preferable as a result of all of the foregoing to develop a harm reduction substance use plan while a patient is in rehab in order to promote a successful discharge. And that brings us to the end of our presentation. And we are very, very excited to respond to any questions or comments that you may have. Thank you so much for listening.
Wonderful. Thank you so much, Andrea, Alexandra, and Bryn. That was a great presentation. So it's now time for a discussion. And I'm just going to remind our audience today that you're able to type your questions into the discussion via the YouTube chat. If you're not logged into YouTube or you'd like to ask a question anonymously, please feel free to send an email to lori.balchuk@utoronto.ca. And I think Lori's also put that information in the chat as well. And just want to remind everyone that questions and comments are welcome, and that questions will be prioritized in the discussion, but we'll make sure that today's presenters receive a copy of all of the questions and feedback and comments. Okay. I'm just going to check here. Let's see, we have a couple questions so far. So the first question is whether or not this paper and your arguments with respect to illicit substances also extend to illicit substances. So whether or not you think that inpatients should be allowed to use these illicit substances as well, or if you think there are any differences.
I would be happy to start our answer, and then I'll welcome contributions from Andrea and Bryn. I'd like to start by saying that, yes, our presentation and our paper focus on illicit substances, meaning, of course, legal substances, and we didn't address illegal substances, and we did that for one main reason. We really wanted to focus on the ethics of the situation, of the problem, of the issue. And we didn't want our response to be mired down in the legalities that would necessarily arise if we were talking about substances that are illegal. Because of course, if you're talking about substances that are their use and their possession is against the law, that brings in a lot of other variables that would have to be considered by institutions and healthcare providers. And it muddies the waters. So we thought that while there certainly would be arguments that could extend to the context of substances that are illegal, we had a more modest, more narrow scope, just so that we could really highlight the ethics of the issue. But that is not to say that principles of harm reduction would not be applicable to the use of substances that are illegal. It just is not where we focused our attention in terms of this work that we did. Would Andrea or Bryn, would you like to add to that?
I'm happy to jump in a little bit just in relation to that last point. So yeah, I think that ultimately I agree with you, Alex, that a legal analysis would really need to be performed. And I recognize that organizations have reason to say that to respond differently. I'm not saying that those responses are necessarily ethical, but from a legal perspective, it seems like there would be reason for organizations to be reluctant to openly permit and to have conversations about illicit substance use on property, given the liability that they may experience. It is interesting to reflect upon the fact that that study that was referenced from BC, that they did extend the pilot project to both people using licit and illicit substances. So it seems like this is being done in some places, but recognizing that organizations would have good reason to pause and that we didn't want to jump into. We wanted to keep a narrow scope because it's interesting to reflect upon the fact that legal substances are actually not permitted in certain settings. And when we think about person-centeredness, how does this potentially conflict? What I would say, however, is that ultimately providing really good care to people who can benefit from rehab is of the utmost importance. And so ethics principles around maintaining trust, ensuring that we are preventing patients from experiencing harm, encouraging transparency and honesty, I think that those would presumably be really important to consider, even when contemplating patients who are using illicit substances right now. So our paper doesn't focus on that at all for good reason. We wanted to keep a narrow scope, but it seems like at least ethics principles may extend to other substances as well. Thanks.
So maybe I can jump in with a follow-up question. So I like the person-centered approach and that contextualization as sort of the primary thing before the harm reduction. I think that's really interesting. But one of the things I'm wondering on the legal side is whether or not, or if you think there's any authority of the institution to monitor, regulate, restrict, prohibit any substances that are legal. So these illicit substances. Particularly when they're off of hospital property. So I know in the case you referenced, she was not in the rehab facility, she was off the property, somebody saw her. So it's interesting to think about whether or not a rehab facility or hospital would actually have any authority at all to weigh in on that or try to restrict that.
I can start. I think that's a really interesting, important distinction, the on property and off property, Angel. So thank you for raising that. Actually, I think in the pilot project, if I'm not mistaken, the use of substances was all off property, which yes, it was involved legal and illegal substances, but it was all off property. So I think that, and the idea was an intentional turning of a blind eye to what happens off hospital property, which does, there is a difference to certainly when you might consider illegal substances, but to permitting the substance on hospital property, in a way, in a very real way, what somebody does when they are not on the hospital property is very much their own decision, their own life. And really the way that it might interact with rehab is that if that consumption of whatever is being consumed off property means that when they return to hospital, if they do return in a timely fashion, et cetera, which would be another issue, but when they return, if they're motivated to try to get better, and if the consumption of the substance off property does not interfere with the work that they're putting into rehab, I think there's a very strong argument to be made that, it has little to do with the rehab setting at all.
Thanks, Alexandra.
And Bryn, did you want to add on to that, or do you want me to jump in?
You can go ahead.
I was just thinking about what you were reflecting upon during our presentation, and just around the importance of harm reduction and about that being person-centered and the whole bit. And I think that, so I can't speak, I am absolutely not a lawyer, cannot speak with any legal authority whatsoever. But just when really thinking about what a healthcare organization is there to do and to provide really good care, and I would hope that harm reduction can become, I guess, just a part of conversations to a greater extent, so that if a person is using a substance of any kind, that if there's reason to believe that it's going to influence their care, their well-being by using off property as opposed to on property, that at least these conversations can be had, because ultimately I think that we're supposed to be there to provide really good care and to hopefully develop a good rapport with patients so that they will receive and want to receive additional support and services from healthcare teams. And I suppose I worry that if, and this is not in any way reflecting upon, like, making a legal reflection, which is what your question was, Angel, but just thinking about the importance of trust and the importance of building a good therapeutic relationship with patients. If, let's say, someone comes into a physical rehabilitation center and they are unable to ambulate off hospital property, and they identified as a person who drank alcohol, who used cannabis prior to having a motor vehicle accident, prior to just being admitted to rehab, it would seem as though it could be very detrimental to the therapeutic relationship, to the trust that this person has with the healthcare system, if we were to say something like, well, it's too bad that you can't ambulate off property to engage in this activity that you're going to engage in anyways post-discharge, but we're not willing to do so. So I am hopeful that some kind of middle ground can be achieved more frequently because of the possible detrimental consequences that can occur either way. I don't even know if that responds to your question, but it's just general thoughts that I have.
That's all great. And there's a lot of nuance in all of those responses that sort of brought up different things to think about, right? So not just the location, but also the role that a healthcare provider might have in facilitating transport to that location, and the sort of the harm reduction strategies we might use to try and make that as safe as possible, whether it was on property or off property. That's all really interesting. Thank you. I'll move on to our next question. So I'm wondering, do you think that people who are addicted to substances, so not just using substances recreationally, so that people who have addiction, if they should be permitted to use the substances while participating in the inpatient rehab?
Do you want to start, Bryn, and we can add on?
Sure, I can speak a little bit to that one. So when it comes to addiction or a substance use disorder, if you want to claim it that way, permitting it to still happen in rehab could still be like a harm reduction approach. But obviously there's a little bit more at play as well with substance use disorders. It could, sorry, I'm trying to get my thoughts together here, but if people addicted to substances are not permitted to use substances in rehab, then we would need to ensure that there's good medical management in place in terms of abstaining from those substances. So I know Alex had talked about this earlier in terms of like different things that are in place medically to assist somebody when they abstain from substances that helps with withdrawal symptoms. So those would have to be very well placed, and management of those withdrawal symptoms would have to be very important. But it could also be the case that there's a heightened duty to keep people safe if an addiction is present, and balancing both the harms of continuing to use that substance, if that is the decision, versus abstaining from it, and then anything that comes along with that, such as withdrawal symptoms. And I will pass it on.
Did anyone want to add to that?
I think I'm okay. Alex, do you want to add on anything?
No, Bryn, that was great. That was a great answer. I don't really, I would just say, of course, in the case of somebody who's suffering from or who's experiencing addiction, forcing abstinence in the absence of medication management of that withdrawal process could not only be incredibly painful, but actually could be lethal. So it's something to be taken very, very, very seriously, just as you said, Bryn.
Thanks so much. So we have another question. So with respect to the opposing argument that you mentioned towards the end of your presentation, I think, so the question is whether there's any data that shows that people who do use either licit or illicit substances actually do not benefit from rehab. So I was wondering about the burden of proof on that claim and whether there's evidence in support of that opposing argument. And if not, like where that burden of proof might lie.
Yeah, I'm happy to start with that one. So actually, I don't think that there is any, which is really unfortunate. It would actually be very helpful if we were able to say like, yes, there is proof that exists that if a person is using any kind of a substance, illicit or just licit, which is the focus of our and the scope of our presentation, that they will not benefit from rehab. I think that there is an assumption that Alex briefly spoke to during our presentation, that if a person is using any kind of a substance, that there may be consequences of using that substance that can influence their rehab. So for example, if a person is more fatigued, if a person is expressing themselves in a certain way in terms of behaviors, if a person is aggressive or behaving in an unruly kind of fashion as a result of using substances, then that would not be beneficial for them. It could be detrimental to staff, to other patients. And so I think there's a lot of assumptions that actually come into play, specifically when thinking about things that could alter a person's impairment or cognition, such as like alcohol or cannabis most specifically. But it doesn't seem, at least to my knowledge, and Bryn certainly deserves the credit for going through the literature with a fine-tooth comb. And I don't think that there was anything that we found that actually spelled out or that proved that using substances in rehab will not allow a person to benefit, so that they could experience negative consequences. But assumptions certainly do exist in practice, and restrictions certainly do exist in practice. And I think that this is really where the motivation for this presentation and corresponding paper came from, is because these things do exist in practice. And we know even from some of the papers we did read that just premature discharges absolutely happen, that conflict arises amongst patients and staff. But it's an interesting question because there isn't anything that I can think of that that suggests that there is this very clear, causal kind of relationship that exists.
Thank you. So we have another question. So they ask, if rehab is a privilege, not a right, then wouldn't it make more sense that a no substance use criteria was part of the admission? And if rehab is not a right, then we could make it such that a person who uses substances is not admitted. So the question really is there a right to accessing rehab? Is it appropriate to have no substances as part of the admission criteria to permit access or not?
I can start this one if you want. Yeah. Okay. So definitely we agree that rehab is a privilege and not necessarily a right, because there are particular criteria that fall into place in order for somebody to be a patient of rehab. And those criteria should still exist. And we're not saying that they shouldn't exist, but we are saying that using legal substances should not prohibit somebody from accessing rehab. That should not be something that is one of the deciding factors on if somebody should receive rehab care or not.
Thank you, Bryn. I agree with that. And I think the language of rights is really very difficult, quite fraught in relation to healthcare. I would not go so far as to say that rehab is a right, but a value that we have as Canadians is that everyone deserves access to healthcare according to need. And saying that substance use, which we know is correlated with socioeconomic status and hardships in life and other, is a barrier to rehab, actually makes a very vulnerable population disentitled to rehab, which is works in unfairness. Actually, more than works in unfairness, like compounds in unfairness. And while there may be behaviors and possible effects down the line, we think those should be addressed, with strategies to address them. But to say outright that there can be no substance use of a patient who's in rehab, yet compounds unfairness. And so yes, we don't think it should be an exclusion criterion, if you will.
Yeah, if I could actually briefly add on as well, I think that there are some really great rehabilitation eligibility criteria that do exist. So one of them is if a person is in acute care and the acute care team thinks that they would benefit from rehab, if they're unwilling to participate in rehab, if it seems like they are just unwilling to really say yes to any of the recommendations that a person is going to put forward, then that unwillingness to participate would preclude them from admission to rehab. And there's a lot of other criteria that are taken into consideration. But coming to your other question, Angel, if there isn't proof that exists that a person's substance use is going to negatively influence their rehab specifically, then it seems like that would not be a rational eligibility criterion to implement. And I know that some organizations certainly do for great intentions. And this is what Alex had initially said in our presentation, really, really good intentions. Some organizations do say that there will be absolutely no smoking or no alcohol use, no cannabis use for our patients. The intentions are really good. But unfortunately, if there is no proof that demonstrates that they're not going to be able to benefit from that care, then it seems like we're unnecessarily preventing people from accessing care that they could gain substantial benefit from. So just really adding on and agreeing with what Bryn and Alex have said, that it doesn't seem like that in and of itself should be an exclusion criterion moving forward.
Great, thank you. So one more thought that I'll slip in, and then we have one more question from the chat. So I wonder, another way of framing some of the restrictions or proposals might actually be under a treatment plan. So what the proposal is, so the treatment plan maybe would include, abstaining from certain things, or agreeing to doing certain things at certain times. So that might be an additional or alternate framing to sort of thinking about how there may or may not be certain restrictions for rehab. But I will get to the question. So this one is specifically for Alex. So they'd like to know if you can confirm that there's no legal obligation to report a potential crime, i.e. possession of illicit substances. So healthcare providers are legally okay to ignore and turn a blind eye to illicit substance use unless there's a reasonable expectation of serious harm to the patient or others. If you can confirm that is the case, and if you'd like to add anything as well.
I think the question is coming to me because of my legal background, and so I'm going to have to say that I am not speaking here as a lawyer today. I'm speaking as an ethicist, and I don't actually have legal expertise. I'm not qualified to answer the question about or I'm not going to weigh in, I guess, unfortunately, on what needs to be reported in terms of substances, unfortunately. It's a very good question, and it just shows that there is absolutely a legal dimension to this that the legal experts should address. Sorry for watching.
If I can actually just add as well, and Alex, I recognize that, yeah, you do have that legal background, which is, I think, why I agree with you, why, of course, the question was, pointed towards yourself. I do think just from an ethics perspective, I mean, you raised a couple of key points, and one thing that comes to mind is that even if, and again, we are not weighing in at all on what needs to be reported, when, why, under what circumstances, what do you do? I mean, that's definitely where hospital legal counsel is necessary to weigh in. And yeah, it's very possible that some currently illegal substances may actually become legal in a very short period of time, right? Recognizing that this happened recently with cannabis, but and again, we're not saying that you do need to, but if it is, let's just say, necessary to actually report on a person's illicit substance possession, use, whatever the case may be. From an ethics perspective, the way in which this is done, I think, would need to be considered. How I think that it would be important for ethicists to think about and to hopefully weigh in on how can we fulfill this legal obligation while at the same time maintaining, building patient trust. How can we maintain a really good relationship and ensure that they're still able to benefit from rehabilitation, even though we need to also report this kind of thing, right? Again, I'm not saying that you necessarily do. I'm not a lawyer. I can't speak to that. But if that ends up being the case in any circumstance, I would encourage people to consider, to at least consider some very key kind of ethics principles and values around how something ought to be reported and discussed with patients and patient involvement and that sort of thing. So yeah, that's all I wanted to add on.
That's great. This is such a rich discussion. And I think it's a good sign that we still have lots more to think about and lots more to talk about on this topic. Unfortunately, we're almost at 5 o'clock, so it's time to draw today's seminar to a close. So I just have a few announcements to make before I thank today's speakers. Our next event will be the Philippa Harris Lecture. That'll be on Wednesday, October 20th. Oh my gosh, that's next week already. Arthur Kaplan will be discussing the ethical lessons from COVID-19, past, present, and applying them to the future of cancer care. To sign up to receive the JCB weekly seminar reminders, please send an email to jcb.info@utoronto.ca. And for the CSB students who are enrolled in the CSB student seminar course, please remember to keep track of your attendance. And last but certainly not least, to Bryn, Alexandra, and Andrea, on behalf of all of us today, thank you so much for your presentation. It was really fantastic.